All right, everyone. Well, that is my cue. We're about a minute before we begin. And so thank you all for joining us today. My name is Laura Evans. I am the Director of National and State Policy for Vibrant Emotional Health. And it is my week to host this crisis jam that is put together with Samhsa, Nashbit, and of course, RI. We are going to have a very jam-packed session for us today, and I think it's going to be a really good discussion focusing in on exclusion criteria and really having a deep dive from Dr. Carol Olsen on this criteria and this topic. I think it's something that we really haven't talked too extensively about, so I'm very excited to have that conversation today. So it looks like we're right at noon. I'm going to go ahead and keep us rolling. We have two new national organizations that have joined the Crisis Jam, and that includes the MTTC Network. Very excited to have them. I know they partner a lot with Samhsa and Nashbit to share information across the country, as well as RTI International. So welcome. Let's keep going to the next slide. All right, so look at all these lovely faces here. These are our top jammers. So these are individuals that have joined us week after week and have been a part of the conversation. So we know that there are a lot of folks here that are active, but I think no one has taken the torch from Dr. Richard McKeon, who is number one, followed here by Brian Hepburn and Brian Sims, and of course, Karen Jones. So a lot of these names and faces you'll recognize either from being featured presenters, hosts, or just really active in the chat. So if you see your photo, thank you for joining us. If you'd like a new photo, please email Karen. We can update your photo. And if your state needs to be updated, let us know as well. We try to make best guesses, but very excited to see all these lovely faces. And Karen just dropped the email in the chat if you want to update any information. So of course, we have the talk.crisisnow.com landing page. This is the page that you can share with your colleagues. It contains a link to go directly to the video. It lets you know what's coming up, as well as how to sign up for the newsletter. And if we scroll down, you'll see a YouTube video. So if you missed a week or wanted to share it again with colleagues or others, you're able to send them the website as well as watch it on YouTube. We have each of the various segments broken out so you can catch the latest hot seat question or state cards. So next slide. And so we have latest crisis news, 4 articles, including this one from The Atlantic on locking people up is no way to treat mental illness. Absolutely agree. And then just a hint for you all today that the crisis hot seat trivia question is based on one of these 4 articles. So make sure that you are up to speed on the latest crisis news. If we go to the next slide, we'll see this was a Seattle Times article on the 3 lessons Washington can learn from Arizona. And this is based on sort of a field trip that Washington delegates, kind of interested party stakeholders took to Arizona to see how they are handling crisis services. So very excited about that. A roll call update on a previous article roll call had mentioned related to the 988 transition. And so this is an update on where some of those bills are currently standing in Congress, where some of the action still needs to occur. So a lot of work to still be done, and we are so grateful for all of the folks and advocate groups who are helping on this front. Next article. And then you'll see here last week, the House Energy and Commerce Committee met to consider markup some healthcare bills, and Rep. Cardenas, who's been very active on 988, spoke to the urgency of 988, support for harm reduction, and I believe those bills did move out of committee. So hopefully we'll see more activity in Congress. Next slide. And then I'm going to turn it over to Shannon Scully from NAMI to give us more information on NAMICon.
Hey all, thanks for giving us this time and space to just promote NAMICon, which is coming up June 14th through the 16th. This is going to be a virtual event with lots of really great content on new research, and there's going to be a track on crisis response. So I'd encourage everyone to click on the link and go learn more about our convention coming up. For those of you who have big fields that have youth and young adults in it, we are making registration free to youth and young adults so that we're able to kind of get our content out to them. So please click on the link, go check it out, and register for NAMICon, and we'll hope to see everyone there. Thanks so much.
Thanks, Shannon. Really excited for that conference. And I know MHA is meeting, I think, next week. So lots of good conferences coming up and talking through 988. So very important. Thank you, staff, for sharing the link in the chat. The quote for this week comes from our Surgeon General, Dr. Vivek Murthy, and it's based on an event that the White House held in conjunction with MTV and others. And so during that meeting, actress and singer Selena Gomez shared her story of struggling with mental illness. And the Surgeon General says, it starts with people standing up and telling their stories. When they hear your story and the story of others, they realize, hey, I'm not alone. And that's really the goal here, is we want people to not suffer in silence and alone. We want them to be able to get the help they need. So timely, so important. And I think it is part of reducing the stigma and helping people to realize that there is help. This moment gets better. And so we really encourage and thank everyone for sharing their stories. Next slide. All right, so it is my pleasure to now turn it over to Dr. Carol Olsen, who is a physician at District Medical Group, Department of Psychiatry at Valleywise Health. And so, Dr. Olsen, I'll turn it over to you.
Okay, thank you very much. Can you hear me okay? Okay, wonderful. So I think it was mentioned I was going to do a deep dive into this subject, and I'm not sure that I can in 15 minutes, but I'm going to do my best to hit some highlights and some very challenging areas that, as a psychiatrist in our Phoenix community for over 30 years, have really not gotten any better, and in fact probably gotten worse in recent years. I'm not a crisis provider, at least to the extent that I'm very much focused on the hospital end of things. And from the crisis standpoint, obviously, one of the goals is to avoid having people come to the hospital. But certainly there's a certain number of individuals who require the highest level of or most intensive level of psychiatric services in a hospital type setting. The particular health system that I work within, Valleywise Health System, it's somewhat unique in our county in that we don't have a multitude of hospitals that take people who are undergoing court-ordered psychiatric evaluation. Actually, Valleywise Health System is the only psychiatric hospital that takes such individuals. And we have three different psychiatric hospitals, in addition to a unit within our acute medical surgical hospital that takes people with a high degree of medical comorbidity. And so I'm going to talk a little bit about some of the challenges that our community has experienced in getting needed care for people who aren't necessarily the type of people with problems that a lot of the private or newly opened psychiatric hospitals have been willing to care for. Next slide. So the first category of such individuals I want to talk about are people who have medical comorbidities along with their serious psychiatric condition. And there's a whole host of different examples of that, but I'm going to hit some of the ones that I see most commonly. The first are people with major neurocognitive disorder, what we used to call dementia, who have serious behavioral disturbance or psychiatric symptoms along with their cognitive issues. And, as we all know, the US population is aging. Dementia is a condition that often comes with age. And so some of these individuals never had a psychiatric problem before. Others had a serious mental illness and then now have developed a major neurocognitive disorder or dementia on top of their prior psychiatric condition. And those patients can tend not to be, or I guess what I should say is many hospitals, psychiatric hospitals, are resistant to taking those patients. Some payers are resistant to paying for their treatment in a psychiatric hospital. It's always kind of bothered me how some of the Medicare managed care plans will try to say that's a neurologic condition instead of a psychiatric condition, even if the behaviors the person is exhibiting are much better treated in a psychiatric environment than in a medical type of environment. Next are people who just have other types of medical conditions that require ongoing treatment in whatever facility or setting they are, which many psychiatric hospitals view as beyond their abilities. And those could be people who need physical therapy, occupational therapy, or respiratory therapy on an ongoing basis. For example, someone might make a suicide attempt and jump from a building and break many bones. If they hadn't had a psychiatric condition and had all those broken bones, they would be going to a rehabilitation facility in order to get physical therapy intensively. Unfortunately, they also are in a psychiatric crisis, and so they need to go someplace where they can get both conditions treated at the same time. And almost all at least in our community, I don't know if it's different in other communities, but almost all psychiatric hospitals cannot provide those type of services. And so those individuals won't be accepted in those facilities. And there's a large variety of other types of conditions. There's people who need dressing changes because they have wounds of some kind or another. There are people who have medical conditions such as unstable diabetes that really need a very close collaboration with medical specialists. And that's not available at most psychiatric hospitals. There are individuals who need psychiatric stabilization, but it's clear that they're going to need long-term enrollment in the long-term care system in order to be discharged from the hospital to a setting where they can have their needs met. And unfortunately, long-term care enrollment can be quite a lengthy process. It's especially lengthy if the person is no longer able to consent to the long-term care enrollment, or doesn't really have access to the financial details that are needed in order to get enrolled with long-term care. In addition, there's a lot of people that don't yet have the degree of functional impairment that would meet the criteria for long-term care, but they still need some type of hands-on assistance in whatever setting they're going to be discharged to. And unfortunately, although it's somewhat changing now, there's still a lot of behavioral health settings that don't provide any hands-on assistance. So those individuals are kind of in a stuck because they don't yet qualify for long-term care, which really has a multitude of settings that individuals like that can go to. But they also have needs that are beyond what is typical for a person with a purely behavioral health problem. And then finally, there's people who do have coverage and do have clear-cut needs for a skilled nursing facility, but it's incredibly difficult often to get skilled nursing facilities to accept patients who have been identified as having a serious psychiatric condition, even if their symptoms have been stabilized, they're fully treated, and they appear to be quite appropriate for such a setting. Next slide, please. This is not my talk was titled as only talking about people with medical comorbidities, but I would be remiss if I didn't talk about some of the other categories of patients that have a great deal of difficulty getting admitted to the hospital, even though they are some of the most severely ill people. One are people with chronic self-injuring behavior. A classic example are people who compulsively swallow things that are not food items. And that often requires repeated medical interventions and often long-term monitoring by staff on a one-to-one basis. self-starvation, people who require tube feeding because of starving themselves. That may be due to a formal eating disorder. It may be that the person is very delusional about food and therefore not eating. And if it becomes to the point where they're risking their life due to not eating, they may end up getting tube feeding, but that is not an intervention that's available at most psychiatric hospitals. And then there are people with treatment-resistant psychosis who may or may not have a component of antisocial personality disorder, but in any event, there are people who have repeated aggression towards caregivers. And that again is a reason why they often are refused admission to psychiatric hospitals, even though it's kind of a, what would you say, makes no sense in that those are the people that most need to be at a high level of psychiatric care to prevent them being a danger to others in the community. Next slide, please. Another broad category of patients who have a lot of difficulty getting admitted to the hospital when they need it are people with neurodevelopmental disorders. Examples of that would be, for example, people with autism who are having a very severe behavioral disturbance, either injuring others or themselves. And they end up getting admitted to crisis centers that are only really intended for short-term stay, and often are very have a lot of stimulus going on in the environment, which is not good for patients like that. And those patients end up getting stuck in those crisis centers for a very long period of time because many psychiatric hospitals are unwilling to accept them for admission. A common comment will be that they don't meet criteria for our treatment milieu, or they will be disruptive to our treatment milieu, and therefore they will refuse to admit them. One reason why, aside from concerns about needing extra staff or needing special expertise in treatment that these hospitals don't have, one other underlying reason why there is resistance to admitting patients with those problems is that they often have a very long delay for placement once they are discharge ready. It is not uncommon for our Division of Developmental Disabilities for such individuals who are coming from a group home who refuses to take them back. It's not uncommon for us to be told, well, they're going to need to build a new group home for this person. And the person could easily be in the hospital for 6 months or longer, waiting for a new group home once they are stabilized and ready for discharge. It's also not uncommon for their payer to say at the point that they have been stabilized for discharge, we're no longer going to pay for continued stay, even though their placement may be months away at that point. Next slide. So I didn't want to just have a big downer of a presentation and not talk at all about anything that I thought might be a potential solution to this. So I'm not, obviously, I know there's many people on this call who are much more knowledgeable than I am about healthcare financing, et cetera. And so I know that some of these solutions may have been thought of or might not make sense, but I'm just throwing them out there as somebody who's worked within the public mental health system for a very long time. And I just think they're things that should be considered, because basically we have a situation right now where in many respects payment for behavioral health services has improved, and there's more parity, and there's a lot of psychiatric hospitals opening, at least in our community. The problem is many of these hospitals all want to serve the same type of patient. And these special categories of patients that I have mentioned are not a small number, are not a small proportion of the total number of patients who need a hospital level of care. But most of those hospitals are not set up to take those patients and not willing to take those patients. So potential solutions, I do believe that just like medical surgical hospitals have an ICU rate that is higher than their regular hospital rate, I think that it should be recognized that there is a proportion of psychiatric inpatients who are very high acuity, are needing very high staffing levels, are very costly to treat, and that the payers should, there should be a recognition within the payment system about that. I think that there really is I'm not sure that med-surg hospitals can open up for business but say we're not going to be able to serve anybody with these large number of commonly occurring medical conditions. But it doesn't seem like there's any regulation once an acute care psychiatric hospital is licensed in our community. There isn't any state agency that will come back to them if it seems like they're only taking the simplest and least complicated patients to say, hey, if you're licensed as a level 1 acute care psychiatric hospital, you need to be able to take the broad spectrum of commonly occurring psychiatric disorders. States have a system of funding level 1 trauma centers so that those centers which need to have a spectrum of specialists on staff are kept financially whole to do that. And I think if indeed the idea is, well, we're not really going to force psychiatric hospitals to take the broad spectrum of patients, then I think to the extent that hospitals are willing to do that, they perhaps need to be recognized in a certain category and compensated appropriately for that. I think that a lot of insurance companies get by with having a relatively narrow network. And therefore, they end up denying continued stay at the acute rate for their members in the hospital, even though, and the member is waiting for a level of care that is part of their benefit package, but none of the contracted facilities are willing to take the patient. And if the payer is able not to pay during that period of time, there's no incentive on the payer to expand their network. So I think that needs to be looked at. I think that the delay in getting people enrolled in, for example, long-term care here in Arizona is really just ridiculous. It can take weeks to get a person on long-term care if it's needed, and if it's needed in order to place them from the hospital, they end up with a large number of unnecessary hospital days, and they end up using Medicare days that unnecessarily. So I think that that's something that should be looked at. We don't in Arizona really have a very effective way to get any type of temporary emergency guardian appointed for someone who needs it. For example, a person who's coming in with significant degree of dementia and can no longer live alone. It's actually quite a lengthy process, often takes 2 months or more to get a guardian appointed who can then consent to that placement for them. And I think that that is also something that leads to a large number of unnecessary hospital days, in addition to a very large hospital bill often for that individual who may have, which is unfortunate, obviously, because ultimately they need whatever estate they have to continue to pay for their placement when they get out of the hospital. And then finally, I don't think that there's really any type of control over skilled nursing facilities deciding not to take someone simply based upon the fact that they have a psychiatric history. So I certainly understand absolutely that skilled nursing facilities may not be able to take people with certain acute symptoms, but we see over and over again that the same patient who sat on psychiatry for a month or more waiting to get admitted to a SNF for their skilled nursing needs, if they happen to get transferred over to the medical side of the hospital, somehow magically they're able to be placed in a short period of time because they're not identified as coming from a psychiatric hospital. And I think that that's unfortunate, and it often leads to people with serious mental illness not necessarily getting their rehabilitation needs met because they simply can't get into a facility that offers those services. And I think that is it for me. I hope I didn't go over, but.
You are fine, Dr. Olsen. This is just so informative and very helpful. So thank you. Before I turn to the roundtable, I do want to see if we can just clarify how you're defining social environment in your slides, and if individuals with a serious mental illness are at higher risk of dementia in the future.
I don't know that I had the phrase social environment in my slides.
I think the question was about milieu.
Oh, I'm sorry.
Yeah,
I'm trying to find it back in the chat.
By milieu, I was referring, that's a term that hospitals use, and it's related, I guess I should have broadened that to say treatment milieu. So in general, it's referring to the therapeutic programming and the overall environment on inpatient units.
Gotcha. Perfect. Well, then let me bring in our roundtable participants. We have Dr. Justin Trevano, the medical director at the Ohio Department of Mental Health and Addiction Services, and Dr. Deborah Peinels, who's the clinical professor of psychiatry at the University of Michigan. So we've got some Ohio and Michigan folks here. We'll start with you, Dr. Trevano, for your thoughts.
Oh, well, golly, I so appreciate being able to offer some thoughts. I would just say Dr. Olsen gave a great presentation on what the different things I work on almost every day, those complex medical needs, the different acuities, the diagnoses that no one really wants to go out there and accept as patients because they take a lot of work and effort. I would say one great thing I have is a partnership of our other agencies at the state level here in Ohio. So, we are very well connected with Department of Developmental Disabilities, with Medicaid. We very much get contacted with difficult admissions for medical or other acuity needs and really problem solve those. And I think that's probably the one message I try to bring in, that problem solving aspect. We do a lot of individual case problem solving that, then may result in some system change or some things I saw there, whether that be payment or some licensing, things that we do at the state level. So, each of these most difficult cases ends up being like an individualized case conference, and that's what it needs to be to solve through those issues. But what Dr. Olsen presented is it's kind of part of the daily routine here, and we're trying to make a difference sort of one case at a time. I would say our state hospitals ultimately act as the safety net for our state in terms of those most difficult cases that have the behavioral issues, the self-harm or the violence. Thank you.
Well, I guess I'll just jump in. And, I think what Dr. Trevino sees in Ohio, I see in Michigan at the state level as well. And we see all over the country. And I thought Dr. Olsen's remarks were really great. These are really the knotty issues. What I would say for this group in the crisis jam is we have to remember that when 988 goes live and the crisis response, there's going to be this need to also look at what are the medical needs of the people for whom a crisis response is necessary. We know that most people won't need this level of medical hospitalization and medical services that Dr. Olsen is speaking to. And so you're already getting to that funnel of people who might need that hospital level of care. Nonetheless, if you get to the point where people get stuck and that flow doesn't work because of all these barriers that you so aptly identified, I think what Justin said is absolutely right. What are the options to sort of bump up the issues? I think about cases like the one you described with somebody with a suicide attempt who had broken legs and also other medical internal injuries. And there was a lot of discussion about whether the services needed to be paid for by the medical health plans versus the psychiatric, the behavioral health carve out. And that required many state actors, the insurers, Medicaid, all to kind of get on the same page to ensure that that a particular individual was just going to get the services that they needed. So I would say, recognize that there are options to seek guidance from state authorities. I would also say what we learned in COVID is that it's really important on the ground with your crisis services to have agreements with your local community systems. Understand that there may be a need for more medical care, that when there's a crisis response, if somebody does need that medical care, you want your medical hospital to be ready and available to serve that individual and to sort through some of those complexities. There's also partnerships with courts, the issues around guardianships and rapid guardianships. In medical services, there are provisions for emergency guardianships. Unfortunately, in psychiatric services, there's often more delays related to that. So I would say that issues of partnerships becomes really relevant too, in terms of solving some of these real complex problems. You are talking about multiple systems, multiple payment sources, multiple regulatory authorities. And then you also have the actors on the ground, the people who are just feeling frustrated and overwhelmed by somebody whose needs may be beyond what they're used to. People with major neurocognitive disorder, people with neurodevelopmental disorders. There's not a lot of there may be a lack of training and experience in working with those individuals. And so that those are going to be important populations to think about as the crisis services move more and more into out-of-hospital responses. And so I think, Dr. Olsen, you brought up some great points, but those would be my thoughts.
Yeah, I think the challenge we've had in Arizona is that we don't really have a division of behavioral health services regulating things in the same way that similar institutions do in other states. Our state folded that agency into the Arizona Healthcare Cost Containment System, which is our state Medicaid program, some years ago. And it hasn't been entirely, this is just my personal opinion, it hasn't worked entirely well to do that, because there doesn't seem to be a whole lot of accountability or oversight in the same way on some of these issues. With regard to the comment you made about guardianship, part of the issue is that to the extent the person is in an inpatient psychiatric bed, it's no longer considered an emergency. And therefore, it's not unusual, especially with some of the delays in court processes because of COVID, to have your guardianship hearing 3 months out because it's not an emergency. It's just the person sitting in a very scarce geriatric psychiatry bed for 3 months of unnecessary inpatient days, but there's no safe place to discharge them to.
Yeah, I guess just another thought is one of the challenges with nursing homes, skilled nursing facilities, is they also have regulatory requirements to minimize the use of certain psychotropic medications. And so there is a justifiable concern about taking somebody who might need those medications, and then what are they going to do when they get into that facility? However, there are also exceptions for people who had pre-existing serious mental illness. And again, that's where I think local partnerships, the crisis response from the call center to the responders, to the mobile outreach, to, bringing people to whatever level of care they need, and then wanting them to move to the next step of their care needs, is really going to require those local partnerships to drive some of these systems. And so that when you pick up the phone to say, hey, I've got this person in my emergency department, hopefully the person answering the phone is kind of friendly and understands what the whole system can look like. And that requires roundtables like this to sort of talk about what are the problems, what are we seeing, how do we address them for our community. And again, bringing in those local and state leaders who have the state people who have the licensing authority and the dollar on the managed care end of things, as well as the local providers who are seeing the issues.
Yeah, thank you, Deb and Dr. Olsen and Dr. Trevano. I think there was a mention of 988 in this transition, and I just wanted to ask a question around kind of the volume, right? How often is this occurring? What are you seeing, Dr. Olsen at Valley-wise, and Deb and Justin, what are you guys seeing from your respective states?
Can you repeat the question? It was related to the 988 system and what? I'm sorry.
The transition. And so for individuals who will need this level of care, and they're being excluded or left behind, how often do you see this kind of coming in? How often do you see this exclusion happening?
Well, I can say on my side, I mean, we have over 300 beds, and at any one day, we have probably 15 people that are awaiting direct admission to our facility from either local hospital emergency rooms or acute inpatient med-surg hospitals who are too medically sick to be accepted at one of our 3 urgent care centers, so our 3 crisis centers, which are kind of the triage facilities. So, and that's just involuntary patients who are awaiting court-ordered evaluation. That doesn't include voluntary patients or patients who are already on a court order for treatment and need to be rehospitalized. So I guess that's part of my frustration, is that, yes, it's very true that on each individual case, you can call so-and-so and try to work something out or whatever. But I don't think that there's a recognition that there are a lot of people who need dialysis who also have serious mental health conditions. We are the only hospital in our community, which is Maricopa County is one of the most populated counties in the United States, that will take those people who need dialysis along with their acute psychiatric care. The way the system has been set up is it's disincentivized acute care hospitals to have psychiatric units. But it's really not very practical for freestanding psychiatric hospitals to be sending people for dialysis. So I just, I feel like there's not a recognition of the fact that this population is aging. They have a multitude of medical and other issues that really require close coordination beyond just the behavioral health experts. But the system really isn't set up to appropriately take care of them. And the sad part is that they end up not getting care they need, getting very substandard care, and dying many years earlier than than someone who doesn't have a behavioral health condition and has that physical health condition.
Perfect. Well, thank you, Dr. Olsen, Dr. Pinels, Dr. Trevano. This has been a really great discussion. There's a lot more questions in the chat, and we'll make sure that we get those over to you. But I think that you're onto something when we start talking about the incentives, particularly from Medicare and Medicaid, and how that contributes to this problem. So thank you again so much. We're going to move on in the discussion, and we're going to bring Representative Davis from Washington State onto the hot seat. And I referenced previously that the question today was a part of one of the articles, I believe, from the Atlantic. So Rep. Davis, your question is based in Miami-Dade County. So Miami-Dade County has trained 7,600 police officers in de-escalation and CIT techniques. From 2010 to 2019, they fielded more than 105,000 mental health related calls. Right, so starting with that as our baseline, how many of the Miami-Dade mental health related calls resulted in an arrest? So your choices are A, 19.
Do you want me to answer aloud or click the little button, or both?
You can do both. Just talk it through with us. What are you thinking here?
Well, I appreciated that you gave me the cheat sheet and mentioned that the question would come from these. So I was trying to rapidly read. So I believe it's letter B, 198, per my rapid speed reading at the beginning of this meeting. Perfect.
Well, it looks like over half of the audience agrees with you. So let's see. Yeah, that was fast. You're right, 198. So thanks to the CIT training and other diversion programs, the county has avoided spending $39 million a year on over 400 years worth of jail bed days. And they also were able to close one of their main 3 jails, which saved another $12 million. So obviously, I think that is, I'm not good at math. I'm not sure if you are, Rep. Davis, but that is less than 1% or 1%. So obviously really great work. Rep. Davis, I know you are our future presenter next week, but wanted to give you space a minute or so to talk through some of the work that you're doing in Washington.
Sure. Thank you, Laura. So I think just, I guess, preview for next week, I'm going to be talking about the work that we've done in my legislative district, which is north of Seattle, to bring a behavioral health crisis receiving facility to the district and kind of what that has looked like. And I will probably also talk a little bit about involuntary substance use disorder treatment, civil commitment for SUD. That's something I've spent a lot of my career working on before being a legislator, and actually just had a 2-hour meeting about it this morning. And if I do say so myself, I do believe Washington is really a leader around civil commitment for SUD and doing it well, and it's been done not well in other areas. And I'll probably talk a little bit about that too, especially as it relates to 988 implementation. So thank you, Laura.
Perfect. Thank you so much, Rep. Davis. Yeah, Washington State is really leading the way, and there's a number of other states doing really innovative work. So really thank you all for the work that you're doing. Like I said, 198 out of over 105,000 touch points. That is really great work being done in Miami-Dade County. So David has dropped the link to the article, and if you're able to do some fast research like Rep. Davis, you can find out a little bit more about this program. So we're going to go through to the next slide, please. And I'm going to turn it over to Stephanie Hepburn to discuss this week's Crisis Talk article.
Thanks, Laura, and feel free to jump in because I'm actually flying solo today. Dr. Xiomara Owens is unable to be here, so it's just me. She is the BHA training director at the Alaska Native Tribal Health Consortium. And what she and I chatted about was how behavioral health aides are so vital in Alaska in the rural and remote areas. And I think this is such an important discussion for any state and any community that has rural and remote areas to read this article and look at the nuances and how it could be applied to their state. So she talked about how, quite obviously, if you're in a rural or remote area, it's harder, it's more difficult to access higher levels of healthcare, and how what really needs to happen is scaffolding a strong safety net. She talks about how BHAs can provide not only a community-based service and keep people and help to stabilize them within the community. It also helps to strengthen that safety net that she talked about. So Laura, if you have any questions, I think just looking at the article, again, applying and looking at your community and how some of these elements could be pulled and work for your state, I think is really essential. But Laura, if you have any thoughts or questions.
Sure. Thanks, Steph. I can't wait to read this. This sounds like a really good article. Does the article touch on, without giving too much away, the work for the tribal nations in Alaska, kind of touching on the work as it relates to marginalized, historically underserved communities?
I think the most that she fleshes that concept out is, the concordance, the cultural concordance that BHAs provide, because typically they live and work in the community and are from the culture that they're serving. So I think that's a really vital element when you're talking about marginalized communities. But I think there's also, I think what you're pointing to is really essential, but so too, I think sometimes people avoid something that they feel is not a topic for them. And let's say they're like, oh, well, we have a rural community, but it's not tribal. So thereby it doesn't apply. And I think it's important to look at this and not have a myopic view. That I think you're right. There's this cultural concordance element, but that's true whether you're talking about American Indians or whether you're talking about, farming communities, in Montana.
Yes, you're so right, Stephanie. There's an element that we can all take away that we can apply to our situation. So thank you so much.
Yes, thanks, Laura.
Yeah, no worries. Make sure that you all check out the articles at talk.crisisnow.com. So at this point, I'm going to turn it over to Dr. John Palmieri for a Samhsa update.
Thanks, Laura. Good to see everyone. Well, first of all, I want to actually introduce a new member of the 988 team, if she's on the call, Chelsea Booth, who is a grants project officer who will be working with James Wright in supporting the state and territory 988 grant program. Chelsea, are you here to say a quick hello?
I am. Just going to turn on my video. Hi, I'm here. Hi, David. So many of you I've worked with in various capacities before. Before I joined Samhsa for the 988 team, I was at the Zero Suicide Institute at EDC, And before that, I was working on the GLS grants and the NSSP grants. So it is great to be back, and I'm really excited to work with all of you. Thanks, John.
Thanks, Chelsea. Really happy to have you join the team. And I know that you know a lot of people really well. So that's a great connection. Also wanted to just flag a couple of things that came out of the White House. So one is an updated fact sheet on strategies to address the mental health crisis, where there are some specific references to crisis services in particular and investments from the administration in crisis services. And then the other document, and I'll throw the links in the chat in a minute, is an executive order on advancing effective accountable policing and criminal justice practices to enhance public trust and public safety. And again, some language in there addressing diversion and access to mental health and substance use treatment as critical components of those practices, which I think is important, obviously, in thinking through our crisis system design. And then I think this came up maybe last time or the time before from Richard, but just wanted to remind folks that the Community Crisis Partnership Grant Program is out for consideration. That those applications are due July 25th. And again, this is designed to create and enhance mobile crisis response teams, particularly looking at communities in high need, with the goal, again, of diverting individuals in crisis from law enforcement. And then the final thing I'll mention, which is not really crisis specific, but I think is something that's worth noting, is the Samhsa Recovery Challenge, which is intended to allow organizations, individuals, groups, participants of any kind to share innovative practices, models being used to promote recovery on the ground, and to demonstrate how those innovations have expanded upon Samhsa's definition of recovery and overcome challenges in incorporating recovery into systems of care. So I will throw that in the chat as well. And then I'll pass it off to Richard for any additional updates. Maybe Richard's not.
Thank you, John. So I'll just take a quick second to claim credit for having been the first person to hire Chelsea to Samhsa. I can't claim credit to be the second person, but I was glad to be able to be instrumental in that earlier part of her career. The main thing I wanted to let people know about was, like, last week, Vibrant and Samhsa convened a meeting that really focused on the question of, from a policy standpoint, how should suicidal calls be directed? Obviously, individuals will make this decision based on whether they dial 911 or 988. But what we wanted to do was to convene experts from the suicide prevention and crisis call center field, from 911, to take a look at these issues. The National Association of State 911 Administrators has weighed in formally with the FCC that suicide attempts should go to still lead to a 911 call. I think that most of us would feel that when suicidal ideation is present, that's a 988 call. But of course, it's not quite as black and white as that. And there are situations that are a bit more gray when preparatory behavior has been taken, but it is not at the level where a suicide attempt has been made. You think of the example of somebody threatening to jump from a high structure, a bridge, etc. That doesn't fall neatly into either of those categories. So this was an attempt to bring people together to discuss those issues, to look at some criteria that are being used at different model programs around the country. So we are hoping to utilize this information in the later this month Policy Academy that Samhsa is doing with 5 states on 988 911 coordination. And we will look to get more information out to the folks on this call as well. Thank you, John.
Thanks, Richard. Back to you, Laura.
Thanks, John. Thanks, Richard. Really appreciate your leadership in this space, and welcome, Chelsea. So now I'm going to turn it over to Megan from Nashbit for our Nashbit update.
No, thank you so much, Laura. There's been so many difficult recent tragedies, and Nashbit is very saddened by these. Our thoughts and our heart go out to the people affected by this event, and of course, our whole country is really affected. And over time, there have been many, but there are also natural disasters, and we thought this would be very good timing to bring attention to the Center for the Study of Traumatic Stress, CSTS. They're part of our nation's federal medical school, the Uniformed Services University, and they're dedicated to advancing trauma-informed knowledge and leadership and methodologies. They're a strong partner of Nashbit, and we've worked with them for a very long time. And so some of the fact sheets they put out could be really helpful in leadership through these tragedies, as well as healing yourself, your families. And so they're just very helpful briefs. And some of them that we're putting in the chat box here, I'll just name, they have many on their website, but one is coping with stress following a mass shooting, brief leadership in the wake of tragedy, safety, recovery, and hope after disaster, helping communities and families recover, helping people after a loss, restoring a sense of well-being in children after disaster, and psychological debriefing after a crisis, and what the current evidence is on that. So please take a look at those. I think all of us could benefit from knowing what they say, even if we weren't directly affected at some point. We can always be helping people through these difficult times. So thank you.
Thank you, Megan. And before we go to the next segment, I just also want to highlight, given what you just spoke about, that we will hopefully be seeing from Samhsa. I'm not sure if John or Richard are able to provide an update on the Children's Crisis Services report. Any update there?
I don't have an ETA exactly, Laura, but I should be able to get an update by next week.
Perfect. Well, no worries. We know that you all have a lot on your plate, and there's a lot going on, but certainly we want to make sure that we're serving children as well. As Megan just mentioned, this is crisis does not have an age limit. So thank you, John, for your work and the work that Samhsa is doing here. And thank you, Megan and Nashbit. At this point, I will turn it over to Sarah Corcoran from Guide Consulting to give us a federal update.
Thank you, Laura. And if we can go to the next slide quickly. Since we are on a recess week, I thought it might be a good idea to talk about what we expect to see coming this month, now that it's June 1st. On the Senate side, on the authorizing process, we saw the telehealth draft from that telehealth working group released last week. We expect to see the other 4 work groups release their own individual drafts of what would go into that Senate Finance mental health package, most likely this month, but there are 4 more groups, and we are hearing that the parity group and the integration group might be among the later of the 5 groups to release their drafts. Markup for that bill will also likely be post-July 4th recess at this point, given that we still need to see those other drafts before they can engage on marking that bill up. On the help side, the Samhsa and HRSA reauthorization process, it is possible that we could see a draft bill of their reauthorization towards the end of this month, but if not, it will be likely right after July 4th recess, because they also likely have a post-July 4th reset, post-July 4th markup on the schedule as well. A couple of weeks ago, the House Energy and Commerce Committee reported to the floor their Samhsa and HRSA reauthorization bill that will have to go to the Rules Committee and then to the House floor. But that could happen this month, but also, again, likely before August recess. No word on what Ways and Means might be doing, but they apparently do have interest in moving forward with something mental health, Medicare related. So that one is still TBD from my understanding of it. And then on the appropriations process, the House Appropriations Committee has said that they will be doing their markups of the individual bills in the month of June. So we expect to see that labor HHS one released and marked up this month. It's seeming like the Senate appropriations process is going to be a little bit later than that at this point. But that is where we are on appropriations and reauthorizations and mental health processes in the committees. I also want to give a quick shout out to my counterpart, Joanna from AFSP. She is not on the chat with us today on the call. She is busy prepping for the AFSP Advocacy Forum, so sending lots of well wishes out to her in a very busy time. That's it.
Yes, thank you, Sarah. Very busy time, but lots of great conversations and conferences. So glad to see AFSP also hosting one as well. So at this point, I will turn it over to Steph Pasternak from NAMI to start us off on a state update.
Thanks so much, Laura. A few states to mention, some good news. Last Monday, Kansas is Senate Bill 19 has passed the legislature, just awaiting the governor's signature at this point. The headline news with that bill is it contains $10 million in recurring state general funds in support of 988, at least through 2026. And there is a 988 coordinating council that is created through that bill that will decide exactly how those funds are spent. Moving over to Ohio, there is also a 988 implementation bill pending there, House Bill 468, that passed the House last Wednesday. This is a pretty simple bill that includes some 988 service definitions and establishes a 988 trust fund. Also, not exactly directly 988 related, but there is an omnibus bill in Minnesota, House Bill 2725, that I just wanted to note as it funded, there's a provision within it that funds and creates crisis stabilization beds for children and youth. This was really aimed at addressing the psychiatric boarding issues specifically for youth. And just noting that Minnesota's legislature has wrapped at this point. And I'll actually turn things over to Jordan at this point to talk about a couple newer developments as well.
Yeah, thank you very much, Steph. Just two quick state updates. The first in New Jersey, that's Senate Bill 311. That is being heard in the Senate Budget and Appropriations Committee on Monday, June 6th. So hoping to see some 988 funding attached with that. The other update that I have, not necessarily 988 related, but I think it's relevant just in light of current events. A bill was introduced on Friday in Illinois. That's House Bill 2740. That would require the lifeline to be distributed with a purchase of every firearm. So the phone number would be dispersed with every purchase of a firearm. And those are my updates. I'll kick it back to Laura.
Thank you so much, Steph. Thank you, Jordan. We're going to continue with our state cards. These are the baseball-like cards that show information of states that have allocated funding fees towards 988 implementation. So thank you. We've got Nevada, Virginia, Washington. I'm going to pause here to see if Rep. Orwell wanted to say some brief words about their visit to Arizona. Or if anyone else was a part of that delegation who wants to share some of the top line items that they were able to take away. Feel free to come on camera and off mute.
I can chime in. This is Jen Stuber.
Perfect. Thanks, Jen.
I would just say it was highly informative, and we were really grateful for the RI hosts. We really got to get a lot of get on the same page as a state about a lot of things, and really kind of move our knowledge base further. So I guess I would just say I highly recommend. Not that I want to give RI any more work because they were so gracious and it was a super large undertaking for them, but I would highly recommend other states try to do that, especially if you're having, some trouble and you have a lot of work to do. It's a really good way, I think, to like jumpstart the work in a state and really, because it's really hard to get everyone on the same page and to start thinking about things in the same way and to set high expectations, which of course Arizona does for all of us.
Perfect. Well, thank you so much, Jen. And, I think we want to also continue that facilitation of information sharing. So if there's more examples and more stories, please let us know. We want to make sure that we're highlighting those. We keep going to the next slide, please. I'm going to turn it over to Paul for literally 30 seconds of the crisis calculator. Paul?
I'm going to keep it to 30, Laura. Look, I think the one thing I'll say I'm excited about is NamiCon is coming. And Hannah and I are going to do a presentation on what it costs. And we're going to look at 988 and crisis services. And we'll dig into the calculator during that session for those interested. So I look forward to seeing some of you there.
Perfect. Thank you, Paul. I think that was less than 30. So thank you for that. Because then I can talk a little bit about moving America's soul on suicide. So we know that we have, I believe, 5 episodes have been published. You see episode 1 here available. There are 2 to 3 more, I believe, that need to be filmed. The most recent that is in production is episode 7 for Craig Miller. And if we move on to the next slide, we have for episode 9, Alexandra Allie Robinson, who is a Spartan elite race runner and has medaled. So very excited to have her share her story. Looking ahead, as previewed, we have Representative Davis from Washington speaking more about standing up a crisis receiving center. Holly Rue will be talking through deaf crisis services from the provider perspective, and happy to see Nashbit's Megan Haupt host that week. And then, of course, Dr. Goldman, Homelessness in Crisis, Rep. Orwell from 988 Washington State Update Perspective. Then, of course, it's Dr. Delphman Ripman, 988 going live July 13th, right ahead of that July 16th transition date, as well as folks from Colorado speaking through about their crisis hub and very interesting enterprise that they have set up. Justin Chase and Rachel Rios Richardson previewing Arizona's 988 roadmap and a caller survey that they had conducted. So lots of good information coming up. Thank you all for joining and staying with us, and we'll see you next week.